Welcome everybody to our webinar about palliative care. We are going to be pulling up slides in a minute. So glad that you're here. Awesome. All right. Well, we have a wonderful presentation today. I'm so excited to be here. So I'm Sherilyn Smith. I'm the Chief Academic Officer at Aquifer. And today our webinar is best practices and new tools for teaching what every student needs to know about palliative care. I am so passionate about this and glad to be here with our panelists. So here's the agenda for today. We're going to have an overview of the palliative care project and talk a little bit about why primary palliative care, this is what is our focus, the key research findings that we got from a needs assessment, and then how we identified the principles of primary palliative care excellence. Then we'll have a great panel about how to teach primary palliative care. We'll have an overview of Aquifer's new excellence in palliative care cases, and we will also have a great Q&A with all of our panelists who are wonderful palliative care educators. So excited about this. So a couple of logistics notes. Feel free to use the chat. Questions that come up, you know, something that you need help with, just if you see somebody you know, say hello. For your questions, please put specific questions for our panelists in the Q&A panel, and we will get to those. So we'll be moderating the chat in the background as well. So here are the panelists and presenters that you are going to get to hear from today. So it's just my great pleasure to be working with Susan Merrill, who's an associate professor of medicine at the University of Washington. And she's also one of our leads for our Aquifer Palliative Care leadership team. So it's just wonderful. Barbara Revel, who's at the Dana-Farber Cancer Institute. She's faculty at the Harvard Medical School Center for Palliative Care, and I've been working with Barbara as well on this palliative care project for more than a year. And then Christine Kondawal, who is at Transitions Life Care. She's an associate professor in the Department of Family Medicine, focusing on geriatrics at the Campbell University School of Osteopathic Medicine. And I'm Sherilyn Smith again, the Chief Academic Officer at Aquifer. So as we get rolling, I would love to hear from you all. So in the chat, put how many hours of palliative care content do your students see? Now, this could be some, hours preclinical. Do they have some sessions? Do you have rotations that are focused on palliative care? Are there sessions with another clinical training? So we would just love to hear from you all what the spectrum of education is for your students. So don't be shy, pop something in the chat. So thank you, Shelley. It looks like nice, a week of rotations and then some hours of lectures and simulation. Recommended rotations. So we're seeing, so a week, great. Again, don't be shy, and nothing required is okay. This is the problem that we're trying to solve. So thank you, Frank. That's exactly where we are and why we are talking with you all today and hearing from our wonderful educators. Okay, so to elective and palliative geriatric medicine, wonderful. So what we'd like to do now is I'd like to introduce the Aquifer Palliative Care Project. We're really building an online course to address the gaps in palliative care learning that you all wonderfully highlighted in the chat. So take it away, Susan.
Welcome. I'm Susan Merrill. I'm a general internist, geriatrician, palliative care doctor, and medical educator at the University of Washington in Seattle. I'm really happy to be giving you an overview of this project today. I got involved with this project because I was trying to lead some efforts to teach medical students primary palliative care at our institution, which is a really large institution spread across a 5-state area. And when I found out that Aquifer was leading a curriculum in this area, I jumped at the chance because I didn't want to be reinventing the wheel on my own in my own silo, and because I knew that Aquifer would put together a quality course through a rigorous evidence-based process. So this course was supported by a grant from the Arthur Vining Davis Foundations. It was designed for undergraduate medical education and health professions education, and the course focuses on primary palliative care knowledge and skills. Why primary palliative care? Although some patients need palliative care specialists, all clinicians should have the skills to provide care to patients with serious illness. This course focuses on primary palliative care, what every medical and health profession student should know to improve outcomes and quality of life for seriously ill patients and their families. So what was the development process for this course? So the grant support was awarded to Aquifer from Arthur Vining Davis in September of 2020. Aquifer put together what I think has been a really fantastic interprofessional group of educators from around the country to put together this course. The leadership team was formed in November of 2020. We then did a stakeholder needs assessment through a faculty survey to a representative group of faculty and student and faculty focus groups. We did a literature review of really any curricula that had been developed and published in primary palliative care for medical and health profession students. And not that surprisingly, for those of us who've been doing this work, there really, other than a really good set of consensus goals and objectives that already exist, there wasn't a comprehensive curriculum that had already been published. In June of 2021, we had a consensus conference and identified our vision and principles for primary palliative care education. We then established learning objectives related to the principles. Case authoring by a great group from around the country began in October of 2021. The initial set of cases will be available to Aquifer curricular partners, meaning that the institution subscribes to all 5 of our core curricula on July 1st of 2022, and then additional cases will be released in the fall. So what were our key research findings from our surveys and focus groups? So in terms of what faculty said about where students learn about palliative care in their program, the majority said that there are some preclinical lectures and discussion. A minority have an elective palliative care hospice rotation. A smaller minority have some education integrated into their core clerkships, and only 12% have a required palliative care or hospice rotation. One faculty member said that palliative care and end-of-life care are ubiquitously underrepresented topics in the medical school curriculum. So in terms of what did faculty identify as gaps, not surprisingly, based on what I just said, they said we need more formal coverage and we need clinical experiences. Students, when we surveyed them and talked to them in focus groups, here were the 5 gaps that they felt needed to be addressed. The differences between palliative care and hospice and managing care transitions, approaching serious illness conversations and specifically understanding what the role of a medical student is in that, navigating patient, family, and team conflicts, managing pain, specifically with opioids, and addressing spiritual and cultural issues and their impact on decisions. This is a map of the common terms that came up with both faculty and students, and not surprisingly, communication skills came up the most, followed by family meetings and conflict management and interprofessional teams. When we ask students, they really want longitudinal learning in palliative care education. They appreciate how important this is. They want preclinical courses that introduce the concepts so that they feel prepared for seeing seriously ill patients. And then they want concepts reinforced, and they want clinical applications in their core clerkships, as well as hopefully dedicated palliative care rotations at their institutions. So now I'm going to go over the vision and the principles that we came up with as part of our process, our consensus process in our leadership group. So our vision is to improve the capacity of the U.S. health profession student to deliver humanistic, compassionate interprofessional care centered around patient goals of care and quality of life, by applying evidence-based methods to alleviate the suffering of seriously ill patients and their families through the delivery of primary palliative care. Here are our 5 principles of primary palliative care excellence. Alignment of care with the goals, values, and preferences of seriously ill patients based on assessed need. Interprofessional collaboration and care coordination between patients, families, healthcare teams, and systems. Evidence-based and holistic approach that addresses the physical, psychological, social, and spiritual domains across the illness trajectory from diagnosis to end of life. Equitable access to high quality, culturally sensitive palliative care services for all patient populations. And number 5, education and advocacy to promote palliative care as a gold standard for serious illness care.
So wonderful. Thank you, Susan, for that great overview. And so now what I would like to do is to move to our panel and have our great educators talk about how they teach palliative care. So we're going to start off with Barbara Revel, who she's just so wonderful. And she's going to tell you about some of her great strategies to teach students palliative care. So I'm going to let you take it away.
Thank you. Glad to be here. I'm Barbara Revel. I am a nurse practitioner at Dana-Farber Cancer Institute. I'm on the faculty of the Harvard Interprofessional Palliative Care Fellowship, which is part of the Harvard Medical School Center for Palliative Care. My teaching happens a lot around clinicians training for specialty palliative practice. However, the things that I'm talking about have also been used with health profession students, in my experience with nursing students, advanced practice nursing students, and I think could be applicable in many venues where you are trying to reach these competencies. Next slide. The principle that I'm going to be talking about is equitable access to high quality, culturally sensitive palliative care services for all patient populations. I'm going to be speaking about developing cultural sensitivity. I think I could argue that my narrative also could touch on principles too as well. Next slide. So I'm going to be talking about art-based education as a type of learning experience to cultivate cultural humility. So museum-based or art-based education is a pedagogy that uses art in the museum space to promote a variety of skills, which include reflective practice, clinician self-awareness, interprofessional teamwork, tolerance of uncertainty, appreciation of multiple perspectives, and is very applicable to developing competencies in cultural sensitivity that are so important. I'm going to speak about our experience, not only in our palliative care fellowship at Harvard, but kind of our pooled experience with 3 other fellowships that are mostly MD-based fellowships at Harvard. Ours is Harvard, Emory, Northwestern, and Yale. So what we do is we have museum visits led by fellowship faculty, sometimes with a museum educator. I happen to have a background as a museum docent. Some of the other fellowships work with a museum educator. We take our entire fellowship class at the beginning of the year, which is advanced practice nurses, MDs, and pharmacy fellows, to the museum. We happen to be lucky enough to be a walking distance from the Museum of Fine Arts in Boston. Not everybody is so lucky. We have also created a virtual gallery tour during the pandemic. So it is possible if people don't have access or don't have the funds to pay for the museum admissions. Next slide. So our teaching methods in art-based education, and this is actually what we do, is group artwork observation. So this is where we use the artwork as kind of the third thing, sort of a primary reference point that allows the learners to safely reflect on sometimes sensitive or personal issues. One of the other benefits of this kind of activity, and we do it in a half-day kind of retreat, is that we're taking them out of that health system setting where and taking them kind of in an area where sometimes they feel a little bit uncomfortable because they might say, well, I don't know a lot about art. And you know how doctors and nurses and health professionals hate to be wrong. So in a way, it creates a level playing field. So we ask them to sit down in front of an artwork, generally an artwork that has some narrative element and enough ambiguity to be interesting for deep observation. We ask them to sit silently and write down what they see. And then we have a facilitator who leads them in a discussion of what it is they see and to get them to share the perspectives without a right or wrong answer kind of context. And this is really, we actually ask them to say things like, what is it you see? What are the colors? What do you think is going on in this artwork? And what is very impressive is that they will see that different people in their class, other learners, are actually getting different, having different perspectives on looking at the same piece of art, which is very much applicable to what happens clinically, where you could be in a room with a group of on your team. Maybe it's a family meeting, maybe it's a patient talking about their experience of pain, and the person maybe in the left side of the room sees something different than one on the right side. The social worker in the room may pick up on something that's very different than the doctor in the room. So sharing these different perspectives is important, and we do this group activity. Then we switch to an individual activity where we ask the learners to go into a gallery, pick an artwork that speaks to something in your own experience. So for example, find an artwork that speaks to your life outside medicine, for example, or speaks to a difficult emotion that you encounter in practice, and write about it for a little bit and think about it. And then we get together in small groups. So again, to keep this sort of feeling safe when people are sharing things that are personal, we have a faculty member or facilitator with maybe 3 or 4 learners. And then we go back around to each learner's artwork, and that person sort of stands in front of that artwork and shares, I picked this artwork because it relates to my experience as, or whatever. And we've just found it's a really, and the idea is to, part of active listening is to share with nobody making any commentary, nobody saying, well, you know, you got that wrong. It's really just a pure sharing and other people listening. And if they have to ask questions, it's for clarifying questions. And we find that this has been really effective in developing group cohesion. Next slide. The feedback that we've gotten, again, this is qualitative feedback from our own fellows and also from the group that I mentioned, 4 fellowships of Harvard and Palliative Medicine fellowships, that students have remarked, and this is also in the literature, that there's a closer attention to observing details, more to focus on keen visual acuity that's essential in clinical practice, not only in communicating to one another, but in documenting what's going on in a patient situation. Tolerating ambiguity, that sometimes the answer is not crystal clear. Flattening the hierarchy that can happen so much in medicine. Appreciating varied perspectives of people looking at the same situation, which I think I sort of alluded to, and preventing assumptions based on sort of a superficial look at something is very important in cultural humility and sensitivity. Slowing down, sitting in front of that artwork and slowing down to really see what's going on, very much a part of active listening and how we understand patients' experience. And overall, we find what has been found in the literature and in our certain personal experience is this really cultivates reflective practice, being aware of what's going on and how emotions in the room may affect you, and self-care. We also have found that when we bring the fellows, we typically bring them, the first time we bring them to the museum is the first week of orientation. They don't know each other yet. And we find that after this experience of the personal sharing that happens, that they leave that museum as a class. And it's a really, really powerful sort of feeling. Next slide. So tips and advice on using art-based education pedagogies in your work. There is a growing evidence base that this is a strategy that can develop these qualities of cultural sensitivity, perception, empathy, reflective practice, resilience, and class cohesion. There's a lot of literature around undergraduate medical education in this, less so in hospice and palliative medicine, but we have found that it's quite effective. I think a very important piece of advice would be you want to have a facilitator that you're working with who knows how to work with small groups, who can be certain to create that kind of safe space for people to feel like they can say whatever it is they see and not have a feeling that there's a right answer or a wrong answer. And someone can really help illuminate the meaning that they're getting from this experience. I think that's my last slide, and I pass on to Christine.
Thank you so much, Barbara. That was incredible. Thank you so much for having me. As in the introduction, I am a clinical educator. I work in the community setting. I work for Transitions Life Care. We're a non-for-profit hospice and palliative care practice serving in the Raleigh area in North Carolina. And if any of you know that area, we are lucky. We have great big universities. So we have professional students rotate and spend time with me, myself, and my teams, interprofessional students. So this will be from a perspective of a clinical educator working in the community setting. Next slide, please. We're going to go back to the principles identified in this project, and I'll primarily focus on today on number 2, interprofessional collaboration and care coordination between patients, families, healthcare teams, and systems. As I mentioned before, I'm very fortunate because I work in the community setting. I am fortunate to have all these opportunities to work and train healthcare students from a variety of our regional health professional schools. That includes School of Nursing, social work, PA school, nurse practitioner school, and of course, DO and MD schools. And because of that, I come from a really unique perspective, and I've recognized in all these knowledge gaps of these students related to palliative care and end-of-life care overall. There's this common lack of skill set that we all probably recognize. And so I felt it was really my obligation to develop something really more robust for all these students that rotate together, that train together, that they need to learn together. And so what I did was, first, I wanted to get more of an assessment, and I sent out an assessment for the regional health professional schools, focusing more on the program directors and the appropriate faculty to get more and engage more. What is now in the curriculum of their schools that will help me understand the needs of all these learners? So the first thing I wanted to know, of course, is achieving competency in palliative care topics and end-of-life care important? And you can see from the survey results, again, thinking this is all interprofessional program directors, majorities say yes, 75%, 13% being unsure, and no for 12%. But significantly, majority of these schools find it an important competency skills for their learners. Next slide, please. I wanted just to highlight a couple of these slides, the results, because I felt that, again, this key information was really helpful for me. It provided me a framework of how I could feel really confident moving forward, of how to develop a curriculum that meet all of the learners' needs. One, of course, was a priority to know is how they felt, how these program directors felt about is teaching their students and leading difficult conversations or leading goals of care conversations. How much of a priority was it for them? Again, remember, these are interprofessional students. Again, high priority, 88% of these faculty felt it was important for their learners to be able to have some comfort in leading goals of care conversations or having conversations that are difficult. Next slide, please. Two other important topics, I think, again, that we all recognize too, is our learners all of them need to have a basic understanding of how to assess, and is it a priority to teach their learners about pain management, including non-pain management for those patients of ours, obviously under palliative care, end of life care, with dyspnea or nausea, vomiting, those kind of symptoms. And again, a majority of the faculty felt it was a high priority for their learners to have that knowledge as a basis for their learners. Next slide, please. So full disclosure, originally this curriculum I developed was meant to be in person. Again, these students usually rotate, whether on their inpatient service or inter-community. But the problem has been COVID. Every time we have our learners come together, we try to walk them through workshops. Because of COVID surges, the learners were often pulled out, and I had to really kind of take a step back and think of how can we really give a robust experience for all of our learners that rotate and spend time with us, and make it something that we can really be flexible and really understand that we're going to be living in this COVID for a while, and I need to be cognizant of really having flexibility of providing this for our learners. And so what I did is I created more of a hybrid model approach. Ideally, the whole idea is this will be kind of a virtual experience. There'll be some didactics that are synchronous and asynchronous, but yet eventually at the end, we'll have an end-of-life care simulation where the students come together. I think what it's really taught me and thought about is I've been getting feedback from other regional schools that are farther distance in our state. For example, we have several schools that are farther out that are too far for a lot of their students to come and travel to rotate with us, for example. Often they're the HBCU schools, smaller schools. They're usually like nursing schools, for example, and they want these kind of skills and knowledge brought to their learners. So actually creating more of a hybrid model, I thought actually maybe I can bring this curriculum more to these schools even that are farther in the state. Next slide, please. And so what we'll be piloting coming up next month is this will be a 4-hour multimodality approach. It'll be some live didactics, again, in a hybrid kind of platform, some short videos using our free resources. Vital Talk obviously has some great examples to use, and the students will be in small group work. If it's virtual, they'll be obviously in their breakout rooms. We all, I think, are comfortable with that now. But ultimately at the end, my team and I have been invited to attend to the schools in person and use simulation labs to put the learners through an end-of-life simulation exercise provided by myself and my teammates, which are interprofessional faculty, nurse practitioner, PA, RN, and social worker. Next slide, please. So our first invitation has been the local Campbell PA program, which we'll go ahead and present this as a pilot. We're looking forward to it. And obviously they invited us to use their simulation labs. So they're really excited to have us provide this learning experience for their learners, which we'll do in June. Next slide, please. Oh, I'm sorry. Sorry, Megan, go back one. I want to give outcomes and feedback. Sorry about that. In regards to looking at some outcome and feedback, I wanted to look at a few things. It's going to be kind of a mixed method of outcomes. One, using the pre-post IPE competency survey instrument. A lot of you may be familiar with it and seen it used in other studies. I thought it'd be a great way for me to kind of look at all the learners and their perspectives with that survey. I wanted to use the pre-post FATCOG survey revised. I think, again, a lot of you may be familiar with it. Is to promote attitudes toward care of the dying. Again, it's widely used towards assessing and measuring attitudes toward care of dying patients. So I will use a short version of it. It's been seen as a brief and valid instrument. Small group facilitator will lead with standardized questions and get that feedback through the students. And then ultimately with the post simulation, they'll go through debriefing with our faculty. And then I really would love to get that student self-reflection. I feel in my experience, students often will share and open up more with their comforts when they have that safe space, which we're pretty confident we'll be able to create for them with that debriefing experience. Thank you. Next slide. And finally, again, I think we've all shared this with each other, is one, create a curriculum that we can get buy-in from our stakeholders. Obviously, because I have so many different learners from different programs in the area, I wanted to see what was something that was common for all of them, that I could get the buy-in to align what their goals and objectives are for their learners to meet their needs. And that's how I was able to create a curriculum that meet all of their needs. The other thing is, working in a community, I'm trying to think what I'm being cognizant of resources, lack of resources, sharing information together. And we're so lucky we have our national leaders here that can help us provide materials to use and frameworks for curriculum development. Obviously, I'm excited for Aquifer as they develop their cases and their coming down the road in the fall. I will certainly be using more of that material as that develops in the line. But I think it's wonderful that we share this information and provide that for each other to support our learners moving forward. And I'm happy to answer questions at the end, but thank you so much for this opportunity. I'm now honored to introduce Dr. Susan Merrill.
Hello, you guys recorded me. This is live me if you're watching this live. Kind of a tough act to follow, really innovative and great programs that the other two panelists have come up with. So again, I'm Susan Merrill. I work in palliative care and hospital medicine here at the University of Washington hospitals and medical centers. I'm the academic lead or one of the academic leads for the Palliative Care Project. I'm also the education director of a local organization called the Candia Palliative Care Center of Excellence. Next slide. So the principle that my intervention addresses is mostly number one, alignment of care with the goals, values, and preferences of seriously ill patients based on assessed need. Probably also number three. Next slide. So I believe about 2016, I was asked to look at how to improve, increase palliative care curricula in the overall curriculum of the University of Washington School of Medicine, which is a really large 5-state medical school. We cover Washington, Wyoming, Alaska, Montana, and Idaho. And as you might imagine, the access to palliative care specialists varies a lot. There's quite a lot of us in Seattle, but we're inundated with requests for clinical rotations from many different learners. There's very few palliative care specialists at all in Wyoming, for example, and it varies in the other states. And we have a lot of students in each class. We have a robust culture of primary palliative care at some sites, but not all. We initially looked at how could we have a 1 week or a 2 week clinical palliative care rotation for every medical student, and we did the numbers, and we were like, oh gee, maybe someday, but definitely not now. So what we've done relatively slowly but steadily over the years is integrate active clinical experiences into our core clerkships for medical students that help them practice some of these core palliative care skills. And for the most part, they are supervised by generalists, so really, truly primary palliative care. Next slide. So we actually have some kind of palliative care learning experience in the surgery clerkship and in the psychiatry clerkship, but the one that we've had going the longest and that I think is most replicable at another institution is our 2 structured self-directed clinical exercises that we have in our internal medicine clerkship. So this is a 12-week inpatient and outpatient internal medicine clerkship, again, spread across 5 states. Certainly, we have more students in our core teaching sites in Seattle, but truly spread across many sites. This is really pretty self-directed, which I think is how it's been successful. It is a requirement. Students are given the instruction. They ask their preceptors to observe them and give them feedback. And we do some faculty development, but probably a number of the preceptors haven't heard very much that this is something that the students are going to do, and they're able to supervise students doing things like delivering serious news or advanced care planning, because this is really part of their core work as a primary care internist or a hospitalist. So students are asked to deliver serious news, with supervision, or to deliver or to observe a practicing clinician delivering serious news. So sometimes that's in the context of a family conference, sometimes not. And then they're also asked to complete advanced care planning with a patient. We have like more basic and then more advanced versions of each of these exercises. So the more basic one for advanced care planning is just that they'll ask a patient if they have selected a durable power of attorney for healthcare or a healthcare proxy. And then we have a very slimmed down set of goals and values questions for them to ask if the patient is ready to do more advanced care planning. And then they're observed by internal medicine faculty or residents. And the students all complete a written reflection online through a web interface that we have. Next slide. So in terms of the outcomes of this, and we flashed a picture of the publication and you can look it up. Again, it's a really pretty self-sustaining exercise, which has been really exciting. They got it that all kinds of news could be serious. Obviously, if you tell somebody that they have cancer or that their prognosis is very poor, it's obvious that that's serious news. But the students also use these skills for things like somebody's renal function is worse and they may have to go on dialysis. They may have to go to a SNF, a skilled nursing facility, rather than go home from the hospital. We're going to have to change their pain management regimen. So I thought they identified that they needed to use these patient-centered skills for a lot of different conversations. Most students completed the exercises without a palliative care specialist. Some did take advantage of, oh gee, my patient has a palliative care consult, I'm going to go to that and I'm going to complete the exercise then. In terms of the advanced care planning exercise, we really felt that students could do a lot of this fairly independently because especially by the end of third year, students are not shadowing, they're doing things with the patients. And about half of them, either they were prepped with their preceptor and then did it and debriefed, or the preceptor was in the room with them, but the student did most of the talking. And 70% of the students were really comfortable with advanced care planning after the exercise. So overall, we feel really good about this exercise, and it's been going on probably about 5 years now. Next slide. So my take home is that you really can incorporate primary palliative care learning objectives into core clerkships in an active way. I really jumped at the chance to be involved with this project. I saw an email and I said, hey, pick me, partly because I think that these cases will allow us at our individual institutions not to reinvent the wheel. I've shared some of my materials in the cases that I've developed, and I really see these cases as, sure, they can be used in the preclinical curriculum and students will get a lot out of that. But I think what's most exciting to me is using them kind of as a just-in-time resource for students to look at something and then go, learn about pain management and then go see the patient that has pain. All right, next slide. Okay, so it's still me here, and I'm going to wrap up this portion by talking a little bit more in detail about the cases. Next slide. So we talked about the vision and the principles, and from the vision and the principles, we came up with topics for cases and recruited a great group from around the country to develop cases, principles of palliative care assessment by the interdisciplinary team, family meetings, advanced directives, interprofessional roles and responsibilities, supporting patients and families in the grieving process. We have a pediatric palliative care case, and then we have a pain management overview case. And those are just the cases that are coming out in July. Next slide. And then we're working now on a number of other cases, pain and symptom management cases, anxiety, depression, and delirium in the context of palliative care, disparities in care and outcomes for patients with serious illness, and then a case about the active dying process and symptoms very close to end of life. Next slide. So this is a new streamlined structure. They may look a little bit different than other aquifer cases you've used. And hopefully they actually all take 15 minutes or less to complete. That's our goal. And there'll be a pilot program, and you can tell us for sure, do they take 15 minutes to complete? But again, I think we really should be able to use these cases just in time. Next slide. Great. So there is one principal case, and that covers key definitions, epidemiology, the key principles, why they're important for patient care, and then harm statements explicitly if you don't use patient-centered communication strategies, for example, what harm could come to the patient. Next slide. And then after students do the principles module, they can pick from the application cases. So they all start with realistic case scenarios like your other aquifer cases. They're concise. They focus on a particular area of a patient encounter and center around a clinical decision question. You can see an example there where students learn about a particular scenario and actually have to make a, I think, pretty realistic real life choice about what to do next. At the end of the cases, there's also a reflection case so that they can think about how this applies to them, and then also some self-assessment questions. Next slide. So the initial set of 7 cases will be available to curricular partners, meaning your institution takes part in our 5 core curricula. And then the full set will be available in fall of 2022, and then individual subscriptions will also be available. Next slide. So there's a pilot program that we're just getting off the ground. If you are an early adopter out there, this will be a group of curricular partner programs that will use the cases with their health profession students and share their innovations and experience, and there'll be an application coming out soon.
Susan, you did a great job. Thank you. And thank you to all of our panelists. I learned so much. And so I hope that Christine and Barbara come on back so we can start our Q&A. And I thought, so everybody else who's still on, please feel free to put your questions in. I'm going to get us started off with a couple of questions. I was taking notes, so I have questions, but we'll also probably talk to each other. So maybe starting with Barbara, so give Susan's voice a little bit of a rest. How might you imagine using what you know about the aquifer cases, in teaching your students? What pops to mind? That's the question for all of you. And I'll just start with Barbara. What are some ideas that you have?
Well, I just think the idea that, it's hard to come up with sort of simulated cases, and the fact that these have been, really well vetted by experts saves you as a faculty a lot of work. And certainly one of the things that we've learned in our literature review is that one of the barriers to primary palliative care education among health professions educators, they either don't really have that expertise, they're not palliators, and they have a lot of content to jam into curricula. And this is one way that it's sort of already there for you. So that's what comes to mind for me.
Great. Christine, what pops to your mind when you're thinking about these cases and what you've been doing?
Absolutely what Barbara said. The fact, Susan, that you are even including a pediatric case, because that has come up too. I've had colleagues of mine, pediatricians, especially the past couple years, more relevantly, because we actually have a pediatric team. We have an outpatient palliative care hospice peds team. And so there's been really more interest in pediatrics in this field. So I'm so grateful because now, again, just piggyback what Barbara said, to have our experts and colleagues that really can help create really robust clinical cases that we can trust and feel confident are have great outcome measures. Those are the things I'm going to use and implement as soon as we're able to do that in the near future. So thank you for thinking of the PEDS team especially.
Great. All right, Susan.
Oh, I have a lot of ideas because I've looked at all the cases. I think we're not saying it's super easy to just kind of get these out there. I mean, sure, you can give people access, but to really integrate them into your curriculum, you're going to want to have a stakeholder conversation. So I was just thinking as other people were answering the question, I actually co-wrote one of the cases, the one on grief and bereavement with Karen Bullock, who I don't know is here, but I think Christine knows her, I believe head of the School of Social Work at North Carolina State. And we worked really hard and we had a really, I thought, dialogue that was educational to me. And our patient is a patient presenting to a family medicine or a geriatrics or a internal medicine clinic. And it's about grief that is discovered in the course of figuring out why he hasn't why the control of his chronic medical conditions has not been as good. So I hope that my internal medicine or family medicine colleagues would say, oh yeah, this student should do this case towards the beginning of the rotation, and then they should pick a patient. They will see a patient who is bereaved, right, during the rotation, and they can refresh their memory about some of the things we talk about a kind of classic bereavement. And there's also a reflective exercise that I've included. That's an exercise that we developed for our palliative care elective courses that they could complete after their clerkship or after their particular interaction with the patient. So it's that kind of thing that I hope we will be able to do. And at some point soon, we'll be developing some curricular materials that people can use.
Great, great. So I as you all were talking, and I was thinking, it's when we think about Aquifer cases, sometimes there's like teeing up. So just exactly what you said, Susan, like getting students ready and saying, yes, you really will see this, and having them prepared. And also bringing it to life. So even saying, let me give you this framework or thinking about it, and here's a safe place for you to go practice and see somebody do this before you have to do it real time. Or if you got some feedback and somebody wants to get better, then being able to refer to these cases and say, let's watch this. Let's see how this is done. I was helped with the advanced care planning case, and there's some beautiful embedded video about how to take a values history. Right. And so, being able to watch somebody do that. And when you say, oh, well, I need to ask about those, but I don't even know how to do it, then having an example right there in front. So those are just some ideas. So I'm watching the chat and Q&A. And so I want to make sure that we open it up to people in the audience if you have specific questions. So please pop them in the Q&A. I'm watching that. And then wondering if I took notes. I have questions for you guys, but I wonder if Christine or Barbara or Susan, you have questions for each other before I start launching into my questions.
Well, I loved Barbara's program, and we're fortunate, again, we live really close to our museum here. And when I was reading earlier about your program, Barbara, how did you even establish that conversation to begin with? Like, how did you initiate to even think about implementing something like that? I'm just curious how that started and that engagement.
You mean the engagement with the museum?
Yes.
I think we just call that, they're used to having groups go through museums, right? School kids, big people, and it was just sort of a, can we take a group through? And actually we initially did it without a museum educator, because there is literature, around what we call this visual thinking strategies, or VTS, which is it's actually a group of questions. And somebody had asked the question earlier, that have a set of questions for people to ask. And so really just engaging with the museum. And generally, when you're bringing a group, some museums would require you go around with an educator, and some would let you bring your own group. There's limitations you've got to be aware of, how many you can have in a group, and so on and so forth. But that's kind of how we started. And actually what's happened at our hospital is they've actually now hired a visual arts director. This is who's a previous museum educator. And so she's delighted to do this kind of work and adapt it. Our Department of Medicine at Brigham and Women's Hospital also already has a program where they take residents into the museum and do a lot of this work. So it's pretty grounded in medical education for some time now, but taking into this area to touch on these domains that cut across all the topics in palliative care, I think is really a fun thing to do.
Yeah, wonderful. Thank you.
I have a question for Christine, and but I do want other people that have questions to be able to ask. Do we have any questions from the group yet? So Christine, how did you go about, do you have an interprofessional group leading and teaching and facilitating, and how did you go? That's been a challenge to do that, and for people to craft away time, especially if you want to do some of it in person. How did you go about kind of getting buy-in for that?
Yeah, great question, because obviously that's a big problem. I myself, because I actually oversee our education and community outreach department and transitions, I have protected time to do this, as well as my nurse practitioner. I know not to say mine, but my associate director of education, nurse practitioner, she has protected time to do this with me. The RN that does this with us, she actually works on the weekends in our hospice house. We have a freestanding 30-bed hospice home, but she's also faculty at School of Nursing at UNC. And this has been something that's been very important and a passion of hers. And this will work for her needs as a faculty member. I have a PA that works on our inpatient palliative care team who used to be faculty where she used to work and wants to get more engaged again as adjunct faculty with the Campbell PA program. So it was kind of easy in regards to a lot of people are so interested in teaching and being educators. So just kind of being able to support them in a way that meets our needs, covering our clinical needs, while also meet the needs of the school. And I'm just very fortunate we have schools that are really truly wanting this, and they really worked with our schedule. So I was able, that's why I had to kind of do 4-hour block in the morning, like a workshop kind of thing, and a simulation, because it works out to meet everyone's needs. And we have clinical support to get protected time to do it. So you're right, you kind of have to balance, like you said, it takes some working with the stakeholders, but if they truly wanted it, they worked with us to provide the time that we needed to. Yeah, thanks, good question.
So Christine, can I ask one question, and then we can, and we have some things popping up in the chat. Can you tell me, like, what would the simulation look like? The EOL simulation, like your interprofessional roles.
Yeah, so I used a lot of, CAPC has a framework for interprofessional. I'm sure a lot of us on all the resources. But with that said, I developed a clinical case. And again, because I have IPE faculty, they're each looking at the case from their lens. And I'm having them answer the questions that I want us all to be able to answer, because when we facilitate it, I want us to all be able to give our perspectives, but then how it works as the interprofessional team. A true model is a patient imminently dying at the bedside with a grieving family member at the bedside. So we're going to demonstrate what that looks like, kind of a real time, and then the learners will go through that process together. based on, again, what they'll get from the didactics of interprofessional team. So a lot of the framework was based on the CAPC curriculum because they offer a lot of that IPE information for us. And then having faculty add and make edits to what was appropriate from their discipline.
Perfect. And I saw in the chat and in the Q&A. So I will tell you that the introductory module from CAPC is amazing.
Yeah.
So looking for a resource to use to give demographics. I think students really like that. I did that with a student focus group and they're like, oh my God, this is amazing. It's amazing. And I just want you to everyone know that we have partnered. CAPC has been a partner with Aquifer through this entire time. And we've had leadership on the leadership group for this project. So I feel like we are very well aligned with CAPC being really focused on providers who are palliative care or providers in the greater world. And we're trying to get people who are students up to the level. So when they're out there in practice, they have even a higher level of skills so they can build with the CAPC content.
I think you all should be proud. I'm sure you are between Aquifer. And again, I know that there's a lot of overlap with our colleagues that are experts with Aquifer, CAPC, and I even use NHPCO. I serve on the North Carolina Medical Board, and I have been referring colleagues of mine to use our resources because there's such a hunger of knowledge of all our colleagues. Obviously, we know that our oncologists, our cardiologists, et cetera. And I'm in the situation where I'm referring our colleagues to use our resources, and I just hear such rave compliments about, oh my gosh, these modules are excellent, or Vital Talk. I mean, we're so lucky we have all these resources we can offer to our colleagues, not only to ourselves, but our colleagues. So again, I'm really excited about what you're all creating, because obviously there's such a great need and we're all going to be using it. So I'm just grateful that you guys have really invested the time for this.
Thank you, Christine. Barbara, Susan, any last words, encouragement, words of wisdom?
I was gonna ask if people, I guess it's more a question, is interprofessional education is just sort of where things are, and I just wondered, what you found most rewarding about that in some of these sessions, because I think it is something that is, finally here, and I just remember one of our trips to the museum, and one of the nurse fellows, he was in this class of all these MDs, and one of the exercises that we asked them to do, this was at the end of their fellowship year, was to answer 2 questions. I used to think blank, 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 and now I think blank, blank, blank. And this nurse stood up in front of her class and said, I used to think I didn't belong in this group. Now I think I do belong in this group, amongst all these physicians who have more experience and different training. So I just thought that was a nice takeaway from the interprofessional.
Wonderful. Wonderful. Thank you, Barbara. That's great. All right. Well, I believe we're at time, everybody. It went so fast. So thank you again to all of our panelists for sharing your great innovations and wisdom. Thanks to everybody who's on the call to giving your time to hear about what's coming. And we will be sending you more information, and we saw a lot of interest in the pilot. So look for more. We're excited to be here and so grateful for everyone. All right, everybody take care. Thank you.